everyone. Today I am going to explain about glaucoma. To know about glaucoma, first we have to know about aqueous humor of the eye. It is a transparent, clear, colorless, watery fluid similar to plasma that fills the anterior and posterior chambers of the eye. It contains 98% water, 2% electrolytes and amino acids. What are the functions of aqueous humor? It maintains the intraocular pressure, that is IOP, to keep the eyeball in spherical shape. It has a metabolic role, that is it nourishes the cornea and lens by supplying nutrition such as amino acids and glucose. It also has an optical function. It is helpful for the healthy vision of the eye. It also has a clearing function. It removes the excretory products from metabolism. So this is how aqueous humor looks. It is a clear, colorless, transparent, watery fluid. So the red colored area represents the aqueous humor of the eye. So the anterior chamber is filled with the aqueous humor and the posterior chamber is filled with the vitreous humor, which is known as vitreous chamber. So let us see the aqueous humor formation or production or inflow. The aqueous humor is produced or secreted from pars plicata, which is a part of ciliary epithelium along the crests of the ciliary processes or ciliary body. Aqueous humor is derived from plasma within the capillary network of the ciliary processes. Three physiologic processes contribute to the formation and chemical composition of the aqueous humor. They are diffusion, ultrafiltration and active secretion. Here we can see ciliary epithelium. This is the ciliary epithelium. This is pars plicata, which secretes the aqueous humor. This is the lens of the eye. These are the suspensory ligaments which hold the lens of the eye to the ciliary epithelium. So this is the ciliary body which secretes the aqueous humor. This is the anterior chamber which is filled with aqueous humor of the eye. These are the suspensory ligament of lens which hold the lens in shape and position. This is the posterior chamber which holds the aqueous humor. And this is the vitreous humor which is present inside the vitreous chamber. So this figure shows the circulation of aqueous humor. Aqueous humor is secreted at the ciliary body. It circulates through the posterior and anterior chambers before it is reabsorbed through the canal of Schlemm. So here you can see this is the ciliary body which secretes the aqueous humor. The aqueous humor flows through the anterior and posterior chambers of the eye and then it is reabsorbed by the canal of Schlemm. So let us see the aqueous humor outflow or drainage. The aqueous humor is primarily drained through trabecular drainage. So 90% is drained through trabecular drainage. It depends on the intraocular pressure. So the route in which the aqueous humor outflow happens is given below. Limbus is the joining point of cornea and sclera that encircle the cornea. So from the posterior chambers, the aqueous humor enters into the narrow space between iris and anterior lens. From here it enters into the pupil. From there it enters into the anterior chamber and then it flows through the trabecular meshwork, especially juxtacanalicular part, where we can observe some resistance to the aqueous humor. And then through the trabecular meshwork it goes into the Schlemm's canal, which is also called channel at limbus. And then it enters into the collector canals, which is also called intrascleral channels. And then it enters into the episcleral and conjunctival veins. And then it enters into the cavernous sinus. So So here you can see the red colored part is corneoscleral area, from where the aqueous humor flows into the juxtacanalicular area, the green part. This is the trabecular meshwork of the eye. From there the aqueous humor flows into the Schlemm's canal and then it is let out through the outlet channel. So this is the aqueous outflow system. So aqueous humor is secreted by the ciliary epithelium, the pars plicata, and then it flows from the anterior and posterior chambers. It goes into the trabecular meshwork. This is the trabecular meshwork, and then it goes into the Schlemm's canal. So the red colored arrow marks indicates the flow of aqueous humor. So this is the aqueous humor pathway. From the ciliary processes, aqueous humor is produced. From there it enters the anterior and posterior chamber and then it enters into the trabecular meshwork which absorbs the aqueous humor, and then the aqueous humor is collected by the canal of Schlemm and then it is let out by the outlet channel. So this is the secondary drainage. So secondary drainage, 10% of the aqueous humor is drained through uveoscleral drainage, which is independent of intraocular pressure. So let us see the route. From the ciliary body, aqueous humor enters into the suprachoroidal space and then it enters into the ciliary body, which is the venous circulation, and then it enters into the choroid and then it enters into the sclera, and from there it enters into the orbital tissue. So this is how drugs act on the aqueous humor of the eye to reduce the intraocular pressure. So the beta blockers, alpha 2 adrenergic agonists, carbonic anhydrase inhibitors, what they do is they reduce the aqueous humor inflow, and the prostaglandin agonists, they increase the uveoscleral outflow, and muscarinic agonists, they increase the trabecular outflow. By increasing the outflow of aqueous humor, they reduce the intraocular pressure in the eye. So this is how the fluid forms here, and it travels through the anterior and posterior chambers, and then this is where the fluid exits, and this is the angle between the peripheral iris and the cornea. This is the angle. So we have seen about aqueous humor. So let us know about glaucoma. What is glaucoma? It is a large group of eye disorders with different clinical features characterized by normal or increased intraocular pressure due to impairment of aqueous humor outflow. So the outflow of the aqueous humor is impaired, so it leads to increase in the intraocular pressure and it leads to eye disorders. What is the normal intraocular pressure? It is between 10 to 21 mmHg. So there are types in glaucoma. There are three types based on manner in which aqueous humor outflow is impaired. The first one is primary open angle glaucoma. It is also called chronic simple glaucoma. It is a progressive disease of insidious onset. That means it starts from the inside of the eye. So what happens in primary open angle glaucoma is there is obstruction of aqueous outflow through trabecular drainage, which is nothing but trabecular meshwork. So the aqueous humor outflow is blocked at the trabecular meshwork. It affects both the eyes. It is called bilateral. There are two other conditions similar to primary open angle glaucoma. They are normal tension glaucoma, where intraocular pressure is not raised but there are signs of damage. And the other condition is ocular hypertension, where intraocular pressure and BP both are raised but there are no signs of damage. So the second type of glaucoma is primary angle closure glaucoma. It is also called closed angle glaucoma. We can see an obstruction of aqueous humor outflow due to closure of angle by peripheral iris. So it affects one eye and it is called unilateral. The third type of glaucoma is secondary glaucoma. It occurs due to other diseases like congenital anomaly, which is nothing but birth defects, inflammation, ocular tumors, increased episcleral venous pressure. Then let us see the epidemiology. Epidemiology is nothing but distribution of disease in a population. So, primary open angle glaucoma, it is most common and it occurs approximately 1 in 200 individuals, and it occurs most commonly in individuals who are more than 40 years of age. 20% of cases of blindness in UK were due to primary open angle glaucoma. It affects male and female equally and it is an inherited condition. Approximately 10% chance of getting primary open angle glaucoma if first degree relative has it. Who is first degree relative? Either the parent or a sibling. These are the first degree relatives. So what about the epidemiology of primary angle closure glaucoma? Approximately 1 in 1000 Caucasian adults who are having an age of more than 40 years are affected by primary angle closure glaucoma. 1 in 100 Asians, Mongolians and Hispanics, 2 to 4 in 100 Eskimos are affected. It is more common in females. Let us see the etiopathogenesis. So, imbalance between inflow and outflow of aqueous humor leads to increased intraocular pressure, which leads to eye damage. So, the optic nerves of the eye are damaged due to increased intraocular pressure. The intraocular pressure is raised because there is an imbalance between inflow and outflow of aqueous humor. So, what happens in primary open angle glaucoma? Due to increased resistance to outflow in dense juxtacanalicular trabecular meshwork and endothelium lining the inner wall of Schlemm's canal, there is an increased intraocular pressure. So this is a normal eye where aqueous humor fluid flows normally and it is not blocked at the trabecular meshwork. So there is no increased intraocular pressure. But in case of glaucoma, there is a buildup of aqueous humor fluid at the trabecular meshwork because of the blocked trabecular meshwork. So this buildup of aqueous humor fluid leads to damage to the optic nerve because of the increased intraocular pressure. So you can see normal fluid flow. Normal fluid flow happens from ciliary epithelium to the Schlemm's canal, and this is the drainage canal. But in open angle glaucoma, there is obstructed trabecular meshwork and drainage canal is blocked, which leads to increased intraocular pressure because of buildup of aqueous humor in the eye. Then what about primary angle closure glaucoma? What happens here is there is a reduced outflow of aqueous humor due to closure of chamber angle by peripheral iris. So this leads to increased intraocular pressure. What are the predisposing factors that lead to closure? So why is this closure happening? It can be anatomical, it can be physiological. So anatomical reasons like lens size, corneal diameter, axial length of globe can be the reasons for primary angle closure glaucoma. So usually the lens size increases over time with increasing age due to slackening of suspensory ligaments. So the lens is held in position by the suspensory ligaments. When there is loosening of the suspensory ligaments, the lens size will vary. So this leads to anterior surface getting closer to the cornea. This leads to shallowing of the anterior chamber. It leads to angle closure and it leads to increased intraocular pressure. So what are the physiological reasons? There are two theories behind the physiological reasons. One is dilator muscle theory. So contraction of dilator muscle leads to posterior or backward movement of lens. This leads to dilation of pupil, which leads to peripheral iris becoming loosened, and it leads to increased volume of aqueous humor in the posterior chamber. And then because of the increased volume of aqueous humor in the posterior chamber, it leads to increased pressure in posterior chamber. The iris bows or bends anteriorly, that is forward. Peripheral iris obstructs the angle, which leads to blockage of drainage canals, and it leads to increased intraocular pressure. Then the second theory is sphincter muscle theory. Contraction of sphincter or constrictor muscle leads to movement of lens anteriorly, that is forward. This leads to constriction of the pupil, which further leads to peripheral iris bending anteriorly forward. So peripheral iris obstructs the angle, which leads to blockage of drainage canals, which leads to increased intraocular pressure. So here you can clearly see the difference between primary open angle glaucoma and primary angle closure glaucoma. In open angle glaucoma, the angle is not closed between the iris and the cornea. The trabecular meshwork is blocked, which leads to reduced drainage of the aqueous humor outflow, which further leads to intraocular pressure increase, and it leads to eye damage. But in primary closed angle glaucoma, you can see that the angle is closed. The suspensory ligaments get loosened, the lens is moving forward, and it leads to closed angle between the peripheral iris and the cornea. So the angle is closed and it leads to lesser drainage of aqueous humor, that is aqueous humor outflow is being blocked, and it leads to increased intraocular pressure, and it further leads to eye damage. So here you can see the difference between open angle glaucoma and closed angle glaucoma. In open angle glaucoma, it is caused by the slow blockage of the drainage canals, and it results in increased intraocular pressure. Wide and open angle between the iris and cornea, and it develops slowly and is a lifelong condition. Symptoms and damage are not noticed. It is a most common condition. 90% of all cases we can see open angle glaucoma. What about closed angle glaucoma? It is caused by blockage of the drainage canals. It results in sudden rise in intraocular pressure. There can be closed or narrow angle between the iris and cornea. It develops rapidly, and symptoms and damage are noticeable. It requires immediate medical attention. So what are the clinical manifestations of glaucoma? Primary open angle glaucoma is usually asymptomatic, that is, there are no symptoms observed. But we can observe changes in the eye. What are those changes? Are increased intraocular pressure, glaucomatous cupping of optic disc, and visual field loss, which is scotoma. So here we can see usually a healthy optic nerve consists of optic cup as well as optic disc. The radius of optic cup and optic disc are similar, but in glaucomatous cupping we can see the cup radius is increasing. Radius of the cup is increasing, disc radius is decreasing. So this is glaucomatous cupping, where the cup radius increases and the disc radius decreases. So in scotoma, what is scotoma? We can see visual field loss. That is, in an image, the person affected with POAG cannot see one part of the image. It is seen in black color. So one part of the image cannot be seen by the patient. This is scotoma, where visual field loss is there. Then what about primary closed angle glaucoma? The symptoms are nausea, vomiting, headache, increased intraocular pressure in the eye, which is rapid and severe, visual impairment, periocular pain, hyperemia, that is increased blood flow to the eyes, redness, eye congestion, dilated pupil, edematous optic nerve head, and cloudy cornea. So here you can see a cloudy cornea, closed angle glaucoma. You can see a cloudy cornea which is white in color, and dilated pupil. The pupil is dilated and there is redness of eye. So there is rapid rise in pressure, headache and eye pain, rapid loss of vision, and closed angle glaucoma may occur more slowly, especially in Asians. Coming to the lab investigations, so the intraocular pressure of the eye is measured by tonometry. Rate of outflow of aqueous humor is measured by tonography. Width of chamber angle is measured by gonioscopy. And scotoma, any changes in visual field, is observed by perimetry. So this is a tonogram from a patient with glaucoma. The units for the outflow facility are given as microliters per minute per mmHg. So this is gonioscopy, where you can find the chamber angle. So you can differentiate between open angle glaucoma and angle closure glaucoma using gonioscopy. So this is the physician's eye, this is gonioscopic lens, and this is gonioscopic mirror. So the physician observes the angle between the peripheral iris and cornea of the patient using the gonioscopic lens, and the mirror present inside the lens will show the image of the angle between peripheral iris and cornea of the patient. So this is perimetry test, where we can observe the field loss, visual field loss. In normal patient, if you see, there is no visual field loss, but in patient with glaucoma, you can observe visual field loss here. So coming to the treatment part, the pharmacological treatment. So in emergency cases, mannitol 20% up to 500 ml slow IV infusion is given. Acetazolamide IV injection is also preferred in emergency cases. In non-emergency cases, the first treatment of choice is beta blockers. So the route of administration is topical, nothing but eye drops. Examples of beta blockers are bitoxolol, cartiolol, levobunolol, timolol, metipranolol, etc. What are the contraindications? Bradycardia, that is decreased heart rate, heart block, uncontrolled heart failure, asthma, COPD. These are the contraindications where beta blockers should not be used. Local side effects on the eye: stinging, burning, pain, itching, erythema. Erythema is redness of the eye. Dry eyes, corneal disorders, anterior uveitis. Uvea is the middle layer of the eye. So uveitis is the inflammation of the middle layer of the eye. Allergic reactions like anaphylaxis, blepharoconjunctivitis. Blepharoconjunctivitis combines the features of blepharitis as well as conjunctivitis. Blepharitis is the inflammation of the eyelid where eyelashes are affected, tear production is affected, and conjunctivitis is the inflammation of the conjunctival layer of the eye. So indications, beta blockers are used in open angle glaucoma. What are the brands available in beta blockers? Betoptic 0.5, 0.25% eye drops 2 times a day BD. So it contains betaxolol. Then another one is Tioptic 1% eye drops BD 2 times a day. It contains cartiolol. Betagan 0.5% eye drops OD or BD once a day or twice a day. It contains levobunolol. Minims 0.1% eye drops 2 times a day BD. It contains metipranolol. Timoptol 0.25% eye drops BD 2 times a day. It contains timolol. Then the next choice of drugs is prostaglandin analogs. So the route of administration is topical, that is nothing but eye drops. Examples are latanoprost, travoprost, bimatoprost. So while using prostaglandin analogs, we have to monitor changes in eye color as it increases the brown pigment in iris. So during drug counseling, we have to advise the patient of possible changes in eye color and to report if any. Indications, it is used in open angle glaucoma, ocular hypertension. Cautions, caution need to be taken in case of iritis. Iritis is inflammation of the iris. Uveitis, asthma, pregnancy, lactation, aphakia. Aphakia is absence of lens of the eye due to surgical removal like in cataract surgery, or due to a perforating wound or ulcer, or due to conditions like congenital anomaly, that is nothing but birth defects. Pseudophakia, pseudophakia is nothing but having artificial or fake lens, and in case of angina. Side effects, coming to ocular side effects, prostaglandin analogs can cause ocular pruritus. Pruritus is itching. Allergic conjunctivitis, conjunctival follicles, papillae, blepharospasm, that is nothing but eye twitching. Asthenopia, nothing but eye strain or fatigue. Brown pigmentation. Blepharitis, irritation, pain, conjunctival hyperemia, iritis or uveitis, thickening and lengthening of eyelashes, cataract, conjunctival edema, eye discharge, photophobia. Photophobia is phobia to light, that is fear of light. Keratitis, keratitis is inflammation of the cornea, deepening of lid sulcus, localized skin reactions on the eyelid, lid margin crusting, eyelid edema, eyelid retraction. Lid retraction is nothing but abnormally high resting position of eyelid. Brow ache, retinal hemorrhage, flare. Flare is nothing but worsening of the disease condition. Visual disturbance, ocular fatigue, burning, dryness, increased iris pigmentation, tearing, crying. Tearing is nothing but crying. Foreign body sensation, cataract, corneal erosion. Systemic side effects are exacerbation of angina, asthma, chest pain, skin rashes, headache, hypertension, asthenia. Asthenia is nothing but weakness. Infection, elevated liver function, dizziness, hypotension, bradycardia. So the brands are Lumigan 300 microgram per ml eye drops once a day. It contains bimatoprost. Another brand is Zalatan 50 microgram per ml eye drops once a day. It contains latanoprost. So the third choice of drugs are sympathomimetics. What is the mechanism of action of sympathomimetics? Enzymes in ocular tissues convert dipivefrin into its active form adrenaline. Adrenaline is an alpha and beta adrenoreceptor agonist. It decreases intraocular pressure by reducing aqueous inflow via an alpha mediated vasoconstriction in the ciliary body and increased outflow due to dilation of aqueous and episcleral veins. It is a mydriatic. So what is mydriasis? It is nothing but dilation of the pupil. Route of administration is topical, that is eye drops. Contraindicated in case of primary angle closure glaucoma, patients who show a shallow anterior chamber, patients receiving MAOIs, monoamine oxidase inhibitors or antidepressants. Side effects, ocular side effects are allergic blepharoconjunctivitis, follicular conjunctivitis, burning and stinging on instillation, conjunctival hyperemia, conjunctival adenochrome deposits. Adenochrome is a chemical produced by oxidation of adrenaline. So we can observe conjunctival adenochrome deposits. Macular edema in aphakic eyes, mydriasis, corneal vascularization and opacification. So corneal vascularization is nothing but formation of new blood capillaries inside the cornea. So this leads to opacification of the cornea. So the cornea appears opaque. Ocular pruritus, discomfort, tearing, hyperemia, conjunctival and lid edema, lid retraction, conjunctival blanching. Blanching is nothing but appearing pale in color. Miosis. Miosis is constriction of the pupil. So the systemic side effects are contact dermatitis, headache, arrhythmias, tachycardia, that is increased heart rate, hypertension, dry mouth or nose, asthenia, bradycardia, depression. Examples are dipivefrin, apraclonidine, brimonidine. Brands available are Propene 0.1% eye drops 2 times a day. It contains dipivefrin, iopidine 0.5% 3 times a day, 1% eye drops 1 hour before and after surgery. It contains apraclonidine, alpha-gan 0.2% eye drops 2 times a day. It contains brimonidine. So these are indicated in case of open angle glaucoma, ocular hypertension who are intolerant of beta blockers or in whom beta blockers are contraindicated. The fourth choice is miotics. Mechanism of action of miotics. They increase the outflow of aqueous humor by stimulation of ciliary muscle and by opening of channels in trabecular meshwork. Miotics are directly acting parasympathomimetics acting on the muscarinic receptors. Route of administration is topical, eye drops. Example is pilocarpine. Brands include pilocarpine 0.5 to 4% eye drops, QID 4 times a day, Minims 0.5% QID 4 times a day, 2% and 4% eye drops, Pilogel 4% eye drops once a day. Onset of action is 20 minutes. So it has a short duration of action and requires 4 times daily dosing. Side effects include, ocular side effects are allergic conjunctivitis, blurred vision, ciliary spasm, induced myopia. Myopia is nearsightedness. Lens changes, lid twitching, pain, pigment epithelial cysts, poor night vision, pupillary block, retinal tear or detachments, uveitis, vitreous hemorrhage. Systemic side effects are bradycardia, bronchial spasm, lacrimation, nothing but tearing, nausea, vomiting, salivation, pulmonary edema, sweating, hypotension, diarrhea, headache and brow ache. Carbonic anhydrase inhibitors. Mechanism of action. Inhibition of carbonic anhydrase 2, the form of enzyme involved in production of aqueous humor in ciliary body, results in a reduction in aqueous humor secretion. Inhibition of other forms of the enzyme results in the side effects. Route of administration: systemic carbonic anhydrase inhibitors are given in the form of injection, IV or IM, intravenous or intramuscular. Topical carbonic anhydrase inhibitors are given as eye drops. Examples of systemic carbonic anhydrase inhibitors are acetazolamide. Topical carbonic anhydrase inhibitors include dorzolamide and brinzolamide. Side effects of systemic carbonic anhydrase inhibitors are acidosis, diarrhea, drowsiness, elevated uric acid, nothing but gout, hypokalemia, reduced potassium levels in the blood, nausea, vomiting, malaise, discomfort, paresthesia, prickling and tingling sensation in the limbs of the body, sulfonamide crystalluria, sulfonamide sensitivity, transient myopia. Topical carbonic anhydrase inhibitors. They have systemic side effects like fatigue, headache, dry mouth, nausea, dyspnea, taste perversion. Ocular side effects like blurred vision, burning, stinging, itching, tearing, conjunctivitis, ocular discharge, eyelid pain or discomfort. Then we also have combination products. Fixed combination of timolol and dorzolamide. It is a combination of timolol 0.5% and dorzolamide 2%. Cosopt was the first topical ocular hypotensive to be marketed. It is well tolerated, more effective than either timolol or dorzolamide alone, and as effective as its two components administered separately. Several studies have shown its efficacy with a response rate of over 80% in patients with initial intraocular pressures over 30 mm Hg. Next one is fixed combination of timolol and latanoprost. A combination of timolol 0.5% and latanoprost 0.005% marketed as Glaucoma was first launched in the UK in 2001. Glaucoma is indicated in the treatment of elevated intraocular pressure in patients with open-angle glaucoma or pseudo-exfoliative glaucoma when topical beta blocker monotherapy is not sufficient. It is administered once a day in the morning. Then comes the fixed combination of timolol and brimonidine. A combination of timolol 0.5% with brimonidine 0.2% is marketed as Combigan and is indicated for its reduction of intraocular pressure in patients with chronic open angle glaucoma or ocular hypertension who are insufficiently responsive to topical beta blockers. The fixed combination has been shown to be superior in reducing intraocular pressure than either brimonidine or timolol alone and is as safe and effective as concomitant treatment with the individual components. Next comes the fixed combination of timolol and travoprost. A fixed combination of travoprost 0.004% and timolol 0.5% marketed as Duotrav has been shown to be more effective than either of its components and as safe and efficacious as the components administered concomitantly. Duotrav is indicated to decrease intraocular pressure in patients with ocular hypertension or open angle glaucoma who are insufficiently responsive to topical beta blockers or prostaglandin analogues. Dose is 1 drop in the affected eye once a day in the morning or evening, but should be administered at the same time each day. Next comes the fixed combination of timolol and bimatoprost. A fixed combination of bimatoprost 0.03% and timolol 0.5% marketed as Ganfort has also been shown to be more effective than either of its components used alone and is as effective as the components used in their usual dosing regimen, that is bimatoprost once a day in the evening and timolol twice a day used concomitantly. The sixth Treatment choice is hyperosmotic agents. It is indicated in primary angle closure glaucoma emergencies. Examples are glycerol and mannitol. Route of administration: glycerol is given orally, mannitol is given in intravenous route. Mechanism of action: it acts by drawing water out of the eye and thereby lowering the intraocular pressure. Onset of action: for glycerol it takes 1 hour to act. For mannitol it takes half an hour. Duration of action: glycerol stays in the body for 3 hours. Mannitol duration of action is 4 to 6 hours. The dose of glycerol is 1 to 1.5 grams per kg. For mannitol it is 1 to 2 grams per kg. Side effects: glycerol has side effects of nausea and vomiting, whereas mannitol has side effect profile of pulmonary edema, cardiovascular overload and stroke. Thank you.